It's time to get started for the virtual town hall meeting for the MGB Center for COVID Innovation. I want to, first of all, welcome everybody to this meeting. It's been an incredible journey over the past few days since this center was formed. We received, I would say, many thousands of requests from people to help. Many generous people offering their time. And we're very thankful to everybody who has joined this call and who has emailed us to provide offers of help on this important problem. This is the mission statement of the center, and it's to facilitate the development of new innovations that flatten the COVID-19 curve and protect frontline clinical staff across the Mass General Brigham community and beyond. Why are we here? Well, we want to educate on what is needed and what we need to know for new innovations to be safely deployed and used. We want to help identify internal and external resources necessary to operationalize these ideas. And we want to identify and empower experts from inside and outside MGB that can move meritorious ideas towards the clinical practice. There are two directors of this center. My name is Gary Tierney. I'm a pathologist and an engineer. I reside at Massachusetts General Hospital at the Wellman Center for Photomedicine in the Department of Pathology, and also a member of the MGH Research Institute. David, can you introduce yourself?
Sure, thanks, Gary. I'm David Walt. I'm also in pathology, but at the Brigham. I reside in the Hale building and also am core faculty member at the Wyss Institute at Harvard University.
Thanks. Can I ask anybody who's on the line to please mute their microphones, please? Okay. So let's talk a little bit about the proposed scope of the center. These are the three main categories: devices, which can include personal protective equipment, swabs, etc., diagnostics, and therapeutics. Another interesting aspect that has come up is data. People have actually said that there may be a use for data which transcends all of the different categories and is important in devices, diagnostics, and therapeutics. Today's focus is going to be on devices. And we're going to have future virtual town hall meetings covering the other main areas of diagnostics, therapeutics, and possibly data. So the plan for the center is to conduct a series of virtual town halls. This is the first one on PPE. We're going to then, from that, people are going to fill out a survey, and we're going to form working groups. And these working groups are going to work in tight coordination and very rapidly to come up with decisions on best paths and then determine strategies for implementation. And the center will help with all of these different elements of the plan. So the agenda from today is first to have talks from key clinicians and administrators to address the current and future COVID-19 needs and educate the community. The speakers are Paul Bittinger from Emergency Preparedness at MGH, Mike Klompus, Infectious Disease at Brigham, Paula Wright, Infection Control at MGH, and I will give a brief summary of the current status and case studies in technology that's already been worked on towards this problem. We will then have a brief question and answers period, and then I will describe the next steps of the center. All right. Paul, can you start us off and talk to us about your perspective?
Sure. Thank you so much, Gary, and thanks to you and David and everyone who's helping to lead this effort. And thank you for all of you who are participating in this effort. This Probably goes without saying, but this is an extraordinary and unprecedented time in terms of the challenges that we're facing. The magnitude of the patient volume that we have already seen and what unfortunately we expect to see, both in the ambulatory arena as well as in inpatient and critical care arenas, far exceeds any threat that we've ever had to face in modern medical history. And the challenges related to specifically our supply chain and our ability to protect our workforce are really, truly extraordinary. We are learning an awful lot of lessons very quickly about this outbreak. And one of the most important, I think, that's worth highlighting when we talk about personal protective equipment needs is how much asymptomatic transmission there is. I think in a lot of previous planning work, we hadn't really anticipated how much an asymptomatically transmitted virus could change how we need to approach personal protection and the operation of our healthcare systems. And we already knew that the supply chain was critically constrained, especially with N95 respirators, surgical masks, others. But looking at how we are having to use our equipment to keep our patients, keep our staff safe is really something that I think none of us had anticipated before. So really where we are right now is that across Partners Healthcare, certainly here at Mass General, we have been retooling just about every aspect of our clinical response. As everyone knows, we are operating in a community that is nearly shut down to support social distancing. We have secured entrances at our hospitals to have almost no visitors, and we are trying to put in policies that interrupt infection control, or interrupt infection transmission, excuse me, and support infection control. In order to do this, we, as I already said, are using PPE differently than we ever had. And I know that many of you who are watching this are quite sophisticated with your understanding of PPE, but I'm going to review some basics just to make sure that we're all using the same language, and Mike Compass will build on this. We, right now, across Partners, have a universal mask policy for staff working in the clinical buildings of the enterprise. This is not just clinical staff, it's all of our staff in the clinical buildings. So certainly physicians, nurses, nursing assistants, others, but it's our administrative, our environmental services, our food service, our security, our other staff. And again, it's because a significant percentage of patients can potentially have COVID, can be at risk for transmitting COVID. And a mask decreases that risk of transmission, both from patients to us, from us to our patients, and makes things safer. To give you a sense of the magnitude of this need, we are in the tens of thousands of face masks per day need across the enterprise to support this strategy. And we are gathering data since the strategy has only been live for a couple of days, but we're trying to figure out whether that's going to result in an increase or a net decrease in our mask utilization as compared to what we were doing before. So masks is a huge need. Masks are again, to try and interrupt the chain of transmission, certainly when providing patient care, but also we have introduced this really in an unheralded way into our operational environment to interrupt the chain of transmission just in general. Different than a mask is a respirator. And again, I know so many of you know these terms so well, but forgive me because we want to make sure everyone understands. A respirator filters what you're breathing in. So a mask, in a sense, protects against what's being exhaled. A respirator, and Mike Compass will say a lot more about this, but it filters what you're breathing in. And an N95 is a kind of respirator. There are other kinds of respirators, but they're all basically filters. And the N95 by far and away is the one that is the one we use most commonly. We do not use as many N95 respirators as we do masks, but both masks and respirators are in critically short supply, and therefore one of the areas where we most need to focus our effort. In addition to the respiratory protection, which is either the mask or the respirator, face shield, something that covers your face, is really in short supply as well. The idea is that we think there is mucous membrane transmission, so we have to protect the eyes, as well as the more we can keep something covering the entire face, there's less chance of fomites, of other infectious particles getting on the front of a mask or a respirator. And we are giving one mask to each employee per day, unless it becomes soiled or damaged. And certainly a greater supply of face shields will help us as well. One other very important part of our ensemble, besides the respiratory protection, the face shields, is the gown. Mike Klompus, who will speak in just a second, as well as other infection control leaders around the enterprise, helped us evaluate different kinds of gowns before we ever thought of COVID, because we do know that taking off the gown is actually one of the most important parts of safe use of personal protective equipment, PPE. We have some evidence now that if you don't take off your PPE, if you don't take off that gown correctly, you actually can aerosolize fomites and put the wearer at greater risk. And so we particularly like the design of the gown that we have currently, because it tears away appropriately without needing to rip or stretch or sort of move in an unfortunate way. And so we do know that our supply of our current gowns, the model we most like, is not as robust as it could be. And so there's a potential need for substitute gowns. I think we would love to focus on what potentially we could do to either recreate our current gown or create a gown with similar kinds of properties to it. Gloves were in somewhat better shape. They're not as constrained as our respiratory protection, our face shields, and our gowns, but they're important for us to look at. And then I think one of the others where we kind of are looking for your help with out-of-the-box innovation is just addressing overall this challenge of aerosolizing particles, aerosolizing procedures. So in our setting, we use a surgical mask, and we use sometimes the term surgical mask or procedure mask or face mask interchangeably. They are mostly interchangeable with some differences relating to their ability to withstand liquids and penetration. But we use a surgical mask, eye protection, gown, and gloves as what we call respiratory viral protection. And then if there's a risk of an aerosolizing procedure, meaning that the infectious particles will be aerosolized into the air, then we have to change to a respirator, to an N95 or some other kind of respiratory protection. Certainly, we're looking at all the ways we can make aerosolizing procedures safer. Aerosolizing procedures are things like intubation or suction, or using a nebulizer like albuterol to deliver a medicine that gets breathed in. We're all in terms of thinking of how we can help support that and make that safer. Last thing I'll say, and then I'll turn it over to Mike, is that the time horizon on this is short. As much as the need is great, I think that we expect the wave to be increasing dramatically in the next few days to week, and that we may only have, say, 3 or 4 weeks until we're at the peak of this outbreak. And so solutions that are much more than 2 to 3 months out in the future are probably going to miss their greatest opportunity to help us. And it's not to say that they're not worth pursuing, but I do want to stress the time urgency, that this is, again, unlike many challenges, I think any challenge we've ever faced, and we don't have a whole lot of time to be able to react. So I can't say how grateful I am enough to Gary, to David, to all of you. This is truly our version of an Apollo 13, Apollo 11. Let's make that clear. I'm so sorry. An Apollo 11 moonshot that we need, and maybe it's the Apollo 13 fix the problems that are thrown in front of us. But I'm so grateful for everyone's effort. Let me turn it over to Mike, and I'll stop there.
Thank you very much, Paul. Mike?
Thanks very much. I want to echo Paul's words. I think he beautifully summarized the current situation and some of our key needs. I'd like to add to Paul's point that we are really on an explosive increase. We're on the upswing of the epidemic curve. We are seeing literally a doubling of the volume of patients that were either testing positive for COVID or being evaluated for COVID about every 2 days. So we feel like more and more is to come, and the fear is that this is about to rapidly overwhelm both our PPE supplies, potentially our rooms, and potentially our life-saving equipment such as ventilators. So I'd just like to highlight a few points where I think some innovations would be particularly welcome. So the first might be in terms of our capacity to be able to do point-of-care testing. So one of our limitations right now is that the turnaround time for a test in the very best case scenario is around 8 hours, in many cases much longer than that. And what that means is that puts a big barrier to our capacity to be able to triage patients appropriately, to put them in the most appropriate space for care, but rather have to come up with makeshift solutions while we wait their test results. It also flows over to our capacity to be able to get our healthcare workers who develop respiratory syndromes back on the job because we have to wait for their symptoms to resolve and testing. In some cases, that testing is taking literally days. So point-of-care testing with rapid results would be an incredible innovation. The next topic on the testing front is more sensitive testing. So one of the limitations right now is that our key test for diagnosing this syndrome is a nasopharyngeal swab, so a stick that goes up the nose to the very back of the breathing system that goes off for a PCR. And the issue over there is that particularly early in the course of the disease, the sensitivity of this test is limited, maybe as low as 70% or even less. And so is there another testing approach that one could take that would have better sensitivity and therefore get a better appreciation of who does and does not have disease, which has massive downstream implications for the infection control management of those individuals as well as the clinical management. Should we be sampling another part of the body instead? Should we be using metagenomics? Should we be increasing the sensitivity of what we do put inside the nose? Thinking through that would be very helpful. Along the same lines, one of the challenges that we face is that after people's clinical syndrome has resolved, we want to work out if they have truly recovered from the infection or not, and more to the point whether they might still be shedding virus and therefore at risk of continuing to propagate the epidemic. We need a way to differentiate a persistently positive nucleic acid test versus true active virus. So the scenario over here is a person comes in, they get their classical syndrome of fever, cough, sore throat, etc. They get over their syndrome, they're clinically well for a couple of days. When we retest those individuals, even a couple of days after their syndrome has resolved, it's not uncommon to find that their nucleic acid amplification test is still positive. And we don't know, is that still active virus that can continue to infect others, or is that simply residual genetic material that's of no clinical consequence? So a test that could differentiate those two scenarios would help. And then switching gears towards the PPE side, as Paul alluded to, we are very fearful of exhausting our PPE supplies, and a constant threat to us is the need to be able to maintain our personal protective equipment for our staff. And I'll say that the PPE shortage has been one of the very vexing parts of this particular epidemic, because it constantly forces us to make to weigh risks and benefits, to make potential compromises over what we would do if in an ideal unlimited state to protect our people, compared to what we have to, the realistic balances we have to make to assure adequate supply. So methods to be able to rapidly increase our PPE production or acquisition capacities would be a tremendous step forward. Along the same lines, new methods to disinfect PPE, so the sort of things that classically have been thought as disposable, or single use, so we can extend their life and reuse them. And I think there are two pieces of equipment in particular that fall into this category. One is the N95 respirators that Paul described. These are kind of like masks that are worn over the face, but provide an extra level of protection by filtering out microscopic particles, as opposed to simply dropping droplets. And also face shields, which are critical to protect the face from splatter from a patient who's coughing or sneezing or otherwise producing droplets. And there are a couple of innovations that have been proposed to try to be able to reuse N95s and face shields. And these include things like vaporized hydrogen peroxide, sterilization or disinfection, use of UV light, use of heat disinfection. So developing more large-scale systems to be able to do that, or single device point of use that could be used by a clinician as they go patient to patient would be helpful. And allied to that is we need methods to assess the safety of these strategies. How do we know that these novel methods are actually getting rid of a critical mass of virus? So if it's possible for our research community, particularly our virologists, to be able to partner on those developing PPE or those trying to develop new disinfection sterilization methods of PPE, to provide this testing methodology to demonstrate that this device that's now gone through UV irradiation or hydrogen peroxide vaporization now is in fact truly safe to use again. And then finally, because we are facing this big burst in patients who are coming to the hospital, a critical fraction of whom have severe pneumonia and will require life-saving breathing treatments, a respirator, breathing machines. We are worried about exhausting our supply of ventilators. And a ventilator is a very sophisticated piece of equipment, costs $25,000 and up. There's a limited supply of them nationally. Is a space for our innovation community over here to come up with novel, rapidly producible ventilators that could, in short order, fill in some of this perceived or anticipated need. Okay, let me stop there, and later on, of course, happy to take questions.
Thank you very much, Mike. Next speaker is Paula Wright, Emergency Preparedness at MGH. Infection Control, sorry. Paula? Paula, are you there?
Paul, try *6.
Thank you. Hi, it's Paula Wright, and I work very closely with emergency preparedness, so I'm not ashamed to be associated with them. Many of what I was asked to speak about, many of the topics have previously been covered by Paul and Mike very thoroughly, so I'm going to just quickly go through droplet types, mask types, and sterility assurance. So as has been noted, there are different types of droplets, large droplets, small droplets, and droplet nuclei. So when Paul was talking about aerosol generating procedures, those are procedures where the respiratory droplets that come out of the mouth and the nose, which are generally large droplets that only travel in a 3 to 6 foot range, can actually be made smaller to the point where they become what we call droplet nuclei, very small particles that kind of stay on the dust motes in the air and can travel further. So the primary type of isolation that we follow for COVID risk is droplet plus contact plus eye protection. So we wear a surgical or procedural mask to protect the person's nose and mouth from being exposed to respiratory droplets. But when those procedures are done and aerosolization occurs, there's the potential for them to become droplet nuclei and mist out and travel further and potentially get past a regular surgical mask. So that's when we need that N95 respirator, which is considered a filtering face piece respirator and filters out small particles. So we certainly need both of those mask types for different situations. And as Paul noted, we're using far more regular surgical / procedural masks than we are using N95 masks. So the third topic, the 3 topics were droplet types, mask types, and I think we've gone through the mask types fairly thoroughly. And just to reiterate that amongst the surgical and procedural masks, there's different levels of fluid protection because basically they're designed for the surgical theater and designed to protect the surgical field from the operator's respiratory droplets, but also to protect the operator from splashes to the face. So there's varying levels of fluid protection, but the lower levels of fluid protection are perfectly acceptable protection for the healthcare worker in terms of protecting them from those large droplets. So in terms of sterility assurance, and Mike kind of referred to this, is that, you know, we've already had some meetings with folks looking at radiation beam and other ways to reprocess N95 respirators. And Mike very nicely detailed the kind of assurance one needs if we're going to begin to reprocess something that we've never reprocessed before. While we don't need sterile N95s, if we want to be able to pass them from person to person, you know, we send them off to someone to be reprocessed, they have to come back able to be used by anybody. So we want to know that any microbial life on the surface of that mask, internally and externally, has been killed. So that's why we're looking at sterilizing them. So having some methodology for validating that the mask is everything that was on it was killed, including COVID-19 or human coronavirus, and also that the filtering capabilities, the structure of the filter media in the mask hasn't been compromised. So we're really, we have lots of sterility assurance procedures for sterilizing instruments in steam and sterilizing instruments and vaporized hydrogen peroxide, but we would also need to develop those validation testing methods for sterilizing items that we haven't sterilized before. So a fair amount of work would have to go into that, so we know that we could safely pass these from healthcare worker to healthcare worker. I am familiar with a process that's being used out at the University of Nebraska where they're using UV to decontaminate, not sterilize masks, but their process requires the mask to be labeled and make it back to the same user, which I think would be operationally incredibly difficult. So I would keep that in the back of our minds. If we're looking at UV, we would really need a procedure that would render that product sterile. I guess my last thought would be that since we're using many more surgical procedural masks than we are N95, I know that there are efforts to develop 3D printed N95 respirators, and I'm involved in that and actually have 2 models on my desk, so that work is ongoing. I would guess if there's the ability to 3D print a surgical/procedural mask, since we need many of those, that might be something that we want to explore. And I don't know if that's possible. And I think I will stop there and ask if there are any questions. I know I'm short on time, but a lot was covered ahead of time, so I will stop for questions.
I think, Paula, we have lots of questions, but we don't have an easy way to do that in real time. So I think we'll just move on to the next section, and then if you're still here during the question and answer period, we'll try and address those then.
Okay.
All right, I'm just going to give a little summary of the technology status. This is, first of all, the work of a tremendous number of people who have spent a lot of time over the past week or two making incredible progress on making different prototypes. This is just a case summary. I think probably there's 10 times more people actually working on this and making progress than I'm even able to present. But this is just an example of the kinds of things that people are now working on and that we're trying to help facilitate through this COVID innovation group. So we've talked a little bit about disinfection and reuse of PPE. There have been many options that have been discussed: gamma radiation, E-beam, UV irradiation, and others. There's been quite a bit of interest in prototyping PPE, rapid prototyping or 3D printing, face shields, which involve 3D printing, laser cutting. There's other machine-free methods. There's been quite a bit of work on 3D printing of N95 respirators, which include printing, filtering, and sealing, and even a full face visor and respirator combination. In addition, there's quite a bit of work ongoing on other novel device development, test swabs. There's a big effort at MIT working on that and other places. Ventilator valves. There's been a lot of news about that. And even automating ambu bags for ventilation and quite a bit of work in that particular area. This is just a little bit of information on a couple of case studies of disinfection and reuse of N95s. At Mass General, somebody who's pioneering this on our side is Orhun Muratoglu. And this is a summary from him where they've taken some N95 masks and brought it to the MIT E-beam facility, which have passed initial fit testing after processing here at Mass General. And I also want to give a shout out to Bob Castaldo here, who's really been the central person at MGH with all of the testing. They've identified industrial partners and irradiated more N95s, and they're going to do fit testing on that. They're also, in next steps, they're going to confirm that E-beam irradiation does not compromise filtering efficiency. As been mentioned by multiple of the speakers so far, one of the big issues is determining whether or not the processing produces sterile devices afterwards. And also has been mentioned, I think, Mike mentioned this, that one of the big challenges is that we need to be able to determine if the processing kills the COVID-19 virus. And of course, there's a lot of logistics surrounding any disinfection, decontamination, or sterilization process. There's also been work going on at UV. Bill, this is an update from Bill Farinelli. There's a lot of people at the Wellman Center for Photomedicine, Dermatology Department, and others who have reached out to us. And they're doing research on using UV to disinfect masks. Actually, there's a group in Kansas that actually has a system up and running, and maybe others around the country. There is UV equipment here on campus, but they're not really designed for disinfecting or decontaminating masks. And industrial partners with different UV lamps and machines have been identified, and it would be possible potentially to get those machines and lamps should UV turn out to be a way to move forward. There's been a tremendous amount of interest from the community and also internally with the researchers here at the hospitals and all of the academic institutions about using rapid prototyping for creating new PPE devices. Most of this is 3D printing, but there's quite a bit of discussion also about using laser cutting, injection molding, and other forms of rapid prototyping in this process. As we've heard, N95 respirators and face shields are two of the forms of PPE that are in high demand. This is in high demand across the Mass General Brigham system, but they're also in high demand in hospitals all around the country. There's a couple of notes I just wanted to mention. With the exception of face shields, so far, there are no validated designs of N95 respirators that exist. There's been a lot of publications about that, but it's important to recognize that validation is a very important aspect of this. And so we need to make sure that whatever's produced is going to be validated and safe. And I think everybody can agree and understand why that is, but it's something that's very important. So just keep that in mind as you're looking at all of the press about 3D printing, and everybody who has an idea or a design, we really do need to make sure that we're putting out technology and PPE that is validated and safe. But here's some examples, some case studies of things that have been done locally on rapid prototyping of different PPE devices. In terms of N95 respirators, we have the Cambridge Hack Space and Lowell makers, among many others who have been working on this sort of around the clock. This group has done some rapid analysis of homebrew N95 designs and looked at issues like the time it takes, the material that's used. Bob Castaldo in particular has been fit testing these here to look at the confidence of the seal. There's been some good progress. There have been 2 printed N95 designs that have passed an initial fit test. These some of them use weather stripping for sealing. The key is getting a seal around the face and the mask so that air doesn't leak in and out. And also been some discussion about using MERV 13 filters and repurposing them for filtration. There's been a lot of work looking at face shields, and I'd like to highlight Mark Sushi and Mark Ottensmeyer and Lowell makers as examples of people who really made a lot of progress. They have both 3D printed and completely machine-free face shield designs, prototypes. The advantage of this is that it's low cost, relatively speaking, it's easy to scale, and a lower barrier of entry for volunteers. And next steps in this and many other efforts is to iterate these designs and validate. And of course, then there becomes coordination of funding, material sourcing, and looking at the liability of different designs. There's also been a tremendous outreach from industrial partners and beyond. Alex Piantowski is one example. We've gotten a lot of contacts through him. And we're now developing a network of companies with 3D printers, design experts, material supplies. And this needs to be folded into the group where we discuss the industry as a resource and reassignment to support healthcare needs. And there have been many, many companies, you can see many of them listed here, many companies who have reached out, 3D printing companies, companies that make textiles, that make clothing, the places like Lincoln Labs and Draper have reached out. And it's just been a tremendous outpouring of support and offer to help. And I would also like to mention that the other academic institutions in the local area have also reached out, and we would love to bring everybody together. MIT, Harvard, BU, Northeastern, many of the academic institutions are all working on similar things. And it's our interest to try and utilize these resources in a focused way as possible. So moving on, what we would like to do is set up working groups in a bunch of different areas where the working groups would basically be focused on a particular PPE device. And just as a reminder, this particular town hall is focused on PPE. We will have future town halls focused on diagnostics and therapeutics and potentially data at a later time. But looking at potential working groups that we could form for PPE, here is a list. Face shields is one, I think. Surgical masks, we've heard about the need there. Goggles for eye protection, gamma and E-beam radiation for sterilization of PPE. UV also is another potential working group for disinfection of PPE. A rapid prototyping of N95 masks, creating ventilators, and we definitely want to have a working group that crosses all of the other working groups, helping them with validation tasks. And this is not a fixed list. This is our starting point, but there may be other working groups that we want to form to address other problems on the clinical front lines. And we welcome your suggestions if you have any proposals. All right, now I'm going to get to a question and answer period. And first of all, I would like to say that I don't have all of the answers. And I would welcome participation from people on the line if they do, or offline. We'll be answering a lot of these questions. This center has just started a couple of days ago, and we're gathering all of the expertise. What I can tell you is that we will have the expertise to answer many of your questions in the very short term. We've received thousands of emails, and some of the questions that have come up in these emails are here on this particular slide. The question number one is, what needs to happen before the ideas and designs from this group are used in hospitals? Basically, we heard from many of the speakers so far that this is an unprecedented time. We have to be able to not only make, but also disseminate these devices in a period of weeks if they're going to have the major impact on the current COVID problem. So we're going to have to find very rapid ways to validate the technologies, to pare down from the hundreds of designs that are posted on the internet to the most promising designs, and then basically test them to the extent possible, and then work on a deployment and implementation strategy. And all of this has to happen over a period of weeks, and that's why it's very important that we have an expert validation working group on our center, so that we can assist all of the other working groups with their validation and deployment tasks. The next question is, what steps need to occur before people can print masks using their own 3D printers? What details on 3D printing from home? What I would say on this topic is we are going to have the working groups that I mentioned before in the previous slide. And if anybody is interested in printing, they should join one or more of those working groups, and a plan for deciding on what the best designs are and for implementing 3D printing, whether it be home printers or whether it be large 3D printing factories. That will be discussed and decided upon in the individual working groups, and then the implementation plan will occur. So I would hold off right now on just printing off mass designs that you would see on the internet. But very soon we're going to be able to try and figure out what are the best designs, and then be able to instruct the larger community as to what methods we're going to be using for 3D printing. So please hold off on printing masks, and join the working groups where these will be discussed in much greater detail, and decisions will be made very rapidly. The next question is, what is the COVID Innovation Center doing to support other hospitals? Dissemination of info. That's a very good question. This center was started between Mass General and Brigham, but it's very clear that there's other hospitals in the local area and nationally that are also in crisis mode. And so one of the things we're going to do as a center is we're going to develop a group of people who are going to be responsible for outreach. And this group of people will be not only surveying the local area hospitals, but will also be working on outreach nationally, both to get information about what are the best methods for solving these different problems, but also to be able to potentially offer our support to other areas of the country that may have problems. And so I think it's important to recognize that we're going to have an entire outreach committee as part of the center that's going to be dealing with those questions. This next question, I don't really know the answer to, so I'm not going to try and answer it. What are the current issues in supply chain that is limiting PPE production and dissemination? Maybe, I don't know if Paul is on the line, or Bob, or Ed, if they have more to say, or Paul have more to say about the supply chain. That is not my particular area of expertise. Is there anybody on the line that has a potential answer to that question?
Hey, it's Debbie here. There's a global shortage of polypropylene, which is core to making everything from some of our gowns to the masks, especially the N95 material. So that's a big limitation actually to ramping up. In addition to being able to actually transport the cargo of the PPE that's actually around. There are import and export restrictions in several of the countries that we usually turn to.
Fantastic, thank you so much. And also, I would say that we're going to have experts on the group that are going to be able to answer all of your questions. So please be patient with us, but I'm sure there's going to be a lot of questions after this town hall, and we will do our best to answer everybody's questions. The next question is, how will the vetting process take place to better understand if the idea is viable? And my answer to that is similar to a previous answer, which is we're going to be discussing those details in the working groups. So I think that it would be really great if you guys joined some of the working groups where everything is going to be discussed in far more detail than what I've had a chance, or the speakers have had a chance to discuss here. But the idea of the working groups is really to do that vetting process, to determine what the best methods are, and focus on the products that are most likely to be successful in the short term clinically. Okay, I think I'm going to move on just in the interest of time. We have thousands of questions. Like I said, we will be responding to those questions right after the town hall, and we'll get back to you shortly. But what I'm going to do now is describe a little bit more on the plan. So what is next? So what we're going to do is, right after this virtual town hall, we are going to establish working groups in all of the areas that I discussed. And working group leaders will be selected, and they'll be communicated within 24 hours of this town hall. Then this center will initiate and coordinate working group meetings. So there will be virtual meetings. There will be lots of them, and it'll be a lot of coordination, but we intend to have meetings starting within a day. The MGB COVID Innovation Center will support all working groups to rapidly focus on action plans and to achieve agreed upon goals. David, if David, are you on the line?
Yep, I'm here.
Okay, so we've been talking about devices, and that's been the focus of this particular virtual town hall meeting. But David would like to say a few words on the future virtual town hall meetings on diagnostics and therapeutics.
Thanks, Gary. Just a few comments before I get to that. So it's great to see that the chat function's being used. There are some great suggestions. The chat will be saved as a file and made available on the website. I know there's people who are asking, how do you get involved in a working group? And Gary will cover that in a moment. This particular town hall meeting was maxed out at 500. I've gotten countless emails saying that they can't get on the line, so it is being recorded. So we'll make sure that we get a message out to everyone that they can watch this town hall again. So just to get to this slide with respect to the proposed scope, today's focus was really on devices with a particular focus on PPE. And as we heard at the beginning, we are prioritizing the needs as defined by the clinical staff. And so, as Gary just mentioned, we need to deliver solutions quickly. That's the whole purpose of this center. And so this is not, we expect this to be in existence for as long as it needs, but the goal here is really to deliver solutions quickly. And there's going to be rapid decision making to select the best options, and that's the whole purpose of the working groups is really for all of you who are involved in each of these areas to make the decisions and then have these decisions be vetted by the appropriate experts. We are planning to resource this at the requisite levels to enable us to move quickly. And also the center will serve as a way to connect people with the needs as well as the solutions, even in areas that perhaps are not covered by what's on the slide. Our goal right now was really to get us to address PPE. That seemed to be the highest priority need. And so we will have additional town halls on diagnostics and therapeutics. These will be organized in exactly the same way that this session was organized, namely that the clinical staff will present what the needs are that they're experiencing. We heard a little bit from Mike Klampus before about the need for fast turnaround and a rapid diagnostic, and also the infectivity of patients who have recovered. And so we'll set these up. Not exactly sure when. Trying to get things scheduled for later this week. If not, we'll do them early next week once we get the working group set up. So Gary will take you through the process for signing up for a working group, and then those of you who are on that will get notified when these 2 additional meetings are held. Gary?
Thank you very much, David. That's very, very good. All right, so here's what to do. So what you can do if you're interested in helping is go to www.covidinnovation.partners.org and sign up for working groups if interested and can contribute. Be ready to get involved and spend time helping to solve real clinical problems. This is a screenshot of covidinnovation.partners.org. And as you can see, there's a button that says Get Started. And if you're interested in participating in a working group, please click that button, fill out that survey, and we'll be parsing through that survey over the next 24 hours. And hopefully we'll have the working groups formed, at which point there will be multiple virtual meetings going out for each of the different working group topics. If you want to get in touch with us, if you have questions, if you have suggestions, please email us at covid_innovation@partners.org. Finally, I just want to thank everybody who participated on the call today. I want to thank Paul, Mike, David, Paula, and everybody else who joined this virtual town hall. for the MGB COVID Innovation Center. Let's get to work. And please, as a reminder, go to www.covidinnovation.partners.org and fill out a survey. Thank you very much, and we really look forward to working with all of you on this very, very important topic.